Hello and welcome to the 2024 spring meetings of the World Bank Group and IMF. We have a full room here. I'm Shakuntala Santharan, Shax for short. Over the next hour, we'll discuss how countries can accelerate progress toward universal health coverage, where everyone, everywhere has access to quality, affordable health care when they need it. You can share your thoughts on this topic at any time using the hashtag WBGmeetings. We have experts in multiple languages standing by to answer your questions online at live.worldbank.org. Please post your questions in the live chat if you're joining us online, or by using the QR codes displayed on the chairs in front of you and around the room if you're here with us. Now, later in the program, we'll hear from ministers of health and finance, leaders in the private sector, civil society, and philanthropy to explore the issues and opportunities. First up, let's get the perspective of two people very familiar with the topic who understand what we need to make urgent progress. Please join me in welcoming Ajay Banga, President of the World Bank Group, and Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization. Greetings, gentlemen. Thank you so very much for being here with us today. Ajay, first, quickly, you've been doing a lot of work fixing the plumbing of the World Bank Group. Why, and what's the aim of that?
So this plumbing question is getting asked a few times, and I think that's because I made the statement that I believe that if you make the bank better and more effective, quicker, faster, simpler to navigate, then that allows you to raise your ambition on the kind of things that you can do, because your ability to execute gets enhanced many times over by the quality of your foundation. So I use plumbing to describe it because I say that you can't build a new house with poor plumbing. That is the logic. So what we're trying to do is to improve the speed, turnaround time. It used to take us 19 months to get a project approved. From the time we started talking about it to approval, we're down by 3 months. We want to bring down another 3 months by the middle of next year. If we get it down to a year, that's really good, given the complexity of what we deal with. We're trying to do things with combining our structure in different countries, 20 countries. We're going to put one country head on top of IFC, MIGA, IBRD, all together. So our client has to deal with one person, one World Bank group, and cut out some of the silos that otherwise are visible. We're working on capital adequacy, change the vision and mission of the bank to include livable planet. There's a whole series of these partnerships with other multilateral banks. We're about to launch a co-financing platform, a digital one, which will enable all the MDBs to work together on co-financing deals. We're looking at standardizing standards across procurement. I mean, I could keep going. It's all the plumbing. It's what makes the bank and its people work quicker, faster, better.
So streamlining everything.
Right.
So here we are today talking about health, with the world facing so many pressing issues. Why are we talking about healthcare today?
Because I think healthcare is foundational. I think that at the end of the day, if you look at people struggling with either the cost of healthcare or the inability to access healthcare, it leads to the worst possible outcomes. I went to Indonesia and saw the work they're doing on stunting. The reality is that a child in the first 1,000 years of their 1,000 days of their existence doesn't get the right kind of nutrition, that has an impact economically forever for that child. They earn between 15 and 20% less every year, forever. If you look at climate change and what it's doing to heat impact on diseases, another issue. Tedros can talk about this ad nauseum, but 2 billion people in this world do not have access to healthcare in a way that they get insurance or they get it free. They end up paying for it out of pocket. That puts them in a cycle of poverty for a long time to come. So we've got to fix what is a fundamental requirement for human existence in the form of healthcare, and we have to make it available at a price that's affordable. That's not that complex to get around your head. It's hard to get done, but you will hear from the Japanese finance minister in a short while. They knew how to do it well, and that's what we are trying to do as well.
So no health, no wealth, as the saying goes. Thank you for spelling that out for us, Ajay. So, Dr. Tedros, where does the world stand on universal health coverage that you've long championed?
No, thank you. First of all, I would like to thank my friend Ajay for inviting me to this very important session. And second, I fully agree with him. Health is the foundation. And as you rightly said, health is wealth. And that's why AJAI and the World Bank takes it seriously. And we're very, very glad to say this. By the way, our partnership is increasing from time to time now. We partner on UHC. We partner on Global Preparedness and Monitoring Board. We partner on Pandemic Fund. We partner on also leading the Health and Finance Task Force. You name it. It's a long list, by the way. So thank you so much for your leadership, AJAI. And on the status of UHC, 140 countries have recognized health as a fundamental right in their constitution. This is very important because it's recognizing health as a fundamental human right, which is a political choice that can help us to do the rest, financing or everything. So that's good. And then the second part is since the birth of WHO, that's 76 years ago, life expectancy has increased from 46 to now 74 average. And this is good progress. Of course, this is living condition improved, improvements in medicine, improvements in public health. It's overall development. It shows overall development. So we're progressing. But if you see the SDG goals directly, if you compare it with the SDG goals, we're off track.
Yeah, very.
And I don't think without a very serious catch-up, we may even reach the SDGs. So we have to work harder, and that's why we're partnering with the World Bank and other partners, the whole UN, with countries, especially countries at the center, to push forward to achieve the SDG goals.
So partnerships clearly key. Dr. Tedros, just talk us through quickly. What are some of the key challenges to achieving universal health coverage?
So the challenges are twofold. One, in terms of service coverage, and second, financial. I think AJAI had already said that. In terms of service coverage, 4.5 million do not have access to basic services. And 2 billion, AJAI said it, face financial hardship trying to seek service. And even as a result, some of them descend into poverty. So that's one of the challenges. So coverage, the first one, the 4.5, but also the financial hardship, which is the 2 billion who can afford. These are the two main ones, but of course there are problems like shortage of the workforce that we need to address, and there is of course a long list of challenges.
And overall aging population as well.
Aging population, urbanization, and now with the pandemics, climate and health, because the climate crisis is a health crisis. So the major trends and problems actually that complicate the health problem.
So those are some very stark figures and daunting challenges. So AJAI, in the face of this, what is the World Bank Group doing to support countries to get healthcare to more people?
By the way, one thing I'll just answer. One thing I would like to say, the issue of, for example, workforce shortages is also an opportunity, because if you think about Africa, and Tedros is an Ethiopian, and if you think about the whole continent, the number of young people who are going to be looking for jobs in the coming 10 to 15 years, one of the ways to give them a really good job is give them the chance to get skilled to provide the kind of service that's going to be required from the investment we're going to make in the coming 10 years in this space. So he's absolutely correct. It is a problem today, but we also see it, both of us, as a way forward for young people. Back to your point, what are we going to do? The bank has been working in 100 countries for a while on what I would call maternal and neonatal kind of effort to improve the delivery of care to women and young babies. And there's done a decent job of doing so. The question really is, if you want to widen your aperture to include the diseases across adolescence and older age. So if you just think about heart attacks, diabetes, blood pressure, those are diseases that are challenging older in life as well. And so if you want to broaden the access for those, then you have to widen your aperture to include that. And that's what we are trying to do in this effort, reach 1.5 billion people over the coming period with the WHO, with other partners, and make that happen by 2030. And reach them means really reach them. Don't just, I don't mean reach as in you put up a center and everybody in the area is counted. This is actually touching the person with a medical appointment, either physical or telehealth, working on these expanded range of non-communicable diseases, and maybe in those 100 countries, but maybe expanded geographies in those countries or new countries as well. And that's the effort we're going to try and put in by now in 2030.
So that's 1.5 billion people in essentially 5 years. How are you going to do that?
6 years, but who's counting? 6 years. How are we going to do that?
How are you going to do that?
How are we going to do that? I think it takes a lot of hard work, a lot of knowledge, a lot of financing, and a lot of partnerships. So let me quickly walk through a little bit of it. Financing is the obvious one. You know, we've got money, yes. We're a money bank and a knowledge bank. But even the money we can put to work will never be enough. We're talking about putting to work 50% more money per year than what we used to spend in healthcare pre the pandemic. You're still going to need money from governments. You're going to need money from the private sector. So let me walk you through this a little bit. If you talk about the countries that are at the lowest end of affordability, mostly IDA countries, they spend relatively little amounts of money per person, $21 per person per year on healthcare. That's not going to get you healthcare workers in remote areas that we're talking about. So we have to give them share financing, concessional and grant financing. But if you're a middle-income country, you may have more money available, but you may not have the right regulatory policies to create the multiplier that you want to create by also bringing in the private sector, but by also clarifying how to get more energy going into this space. And I think there we can help with incentivizing them through our money to create the right regulatory platforms, the right policies. And Tedros can talk to you about regulatory policies all day long, but that could help a lot. If you get the private sector involved, once they have some clarity, you could do things like focusing them on the manufacturing of PPE, manufacturing of essential medicines, something that Tedros had a nightmare of during COVID. Ask him, he will tell you. And if you could also get them involved with, for example, putting the right vitamin supplements into processed foods so that you enhance health right from the basic consumption. So there's a number of things. Some of these are more likely to happen in some countries, some in others. The point is, this financing has to be catered for the country and its stage of development. In the same way, knowledge has to be catered for the country and its stage of development. If it's basic knowledge, are you talking about putting up a primary health center or a hospital, which is better at what stage of development? Tough choice, but a conversation to be had. If it's later discussions and conversations about, does this country need geographic expansion? Does this country need new skills? Does this country need affordability? What's the logic of what that country needs to break through its barriers on delivering its share of the 1.5 billion? And that's kind of the knowledge part. And the partnership part, you know, there are a lot of people in the audience. I'm sure Gavi is here and others are here. They're all part of this game. You kind of need to bring all shoulders to the wheel. But since we've got Tedros here, he has what I would call domain expertise beyond limit, technical expertise beyond limit. What do we bring? We bring a diversification of knowledge. We understand water, we understand climate, we understand agriculture, we understand different things. We understand how those connect to health challenges. We can bring that knowledge as a partner, not just our financing, not just our ability to advise governments on regulatory policy, but our ability to help even him understand the intersections between these different causes of healthcare problems in the intertwined challenges that we are going through. So it's a long answer. It needs a lot of work. It's going to be really hard work between now and 2030. I'm sure we will make mistakes along the way, but we are determined to get this done.
You certainly got your work cut out for you, right? So partnerships, financing, and the sharing of knowledge, all vital. Dr. Tedros, what do you hope to see in global health in 5 years? Or 6 years?
In 6 years. By the way, the two things which are very important with regard to making progress are, one, a political commitment. I can add to that. Of course, financial commitment also, he had said that. Political commitment, we have 140 countries who recognize health as a human rights, and we have 140 countries who recognize health as a fundamental human right, and we hope the other countries will do. Because health is a political choice. When they do that, then the rest comes, including finance. Then the second is the financial commitment. In the financial commitment, there is a way. You know, there are finance ministers here, and we expect you to increase public spending. You know, commitment to universal health coverage or health for all, of course it's ambitious, but it's possible. One example that comes to mind is the United Kingdom. After the Second World War, when its economy was in its knees, it actually declared universal health coverage. The Lord Beveridge model started immediately after the Second World War. So economic status cannot be an issue. You can start with what you have. The key is the commitment, and then you can build up. So I think the political commitment and finance are important. Then what do I expect in the next? Of course, I said earlier, to get better or to add years into your life expectancy, and then we need especially to focus on mothers and children to reduce mortality. And it can be done. By the way, Ajay raised when I was Minister of Health in Ethiopia. Just in few years, with the introduction of primary health care, that maternal and under 5 mortality started to decline significantly. So that's what I wish in the next 5, 6 years. Still, there could be a significant cut in many of the countries, especially who have high burden of maternal and child health. And this could be done through a combination of promoting health, especially addressing the root causes of ill health, focusing on the determinants, because many of the health problems are in the food we eat, in the air we breathe, in the environment we live in, our lifestyle, and so on. And we should start from there. And the second is the access issue we said. Universal health coverage, but with primary health care at the foundation, because primary health care is key to cover the basic services. More than 80%, by the way, can be covered using primary health care. And primary health care is also the ears and eye of the health system, and it can help us to prevent outbreaks, but at the same time, if not, to detect early and manage. So investment in primary health care is key. And from my own experience in Ethiopia, World Bank was a major player in building the primary health care, which made a good impact. And of course, the pandemic, preparedness is very important, and we're investing in that. And then investment in science, data, and technology is very important. And like the World Bank, reforming WHO itself to be fit for purpose will be very important. But all this, the center is country. So what do we do at the country level, and what capacity do we build at the country level, and how do we help countries to achieve is crucial. But at the end of the day, the ownership is the countries. We're only here to help. And the World Bank and WHO, that's exactly what we're saying. And the results come at the country level. So I cannot say we'll get this result, but sure, if we can partner effectively, and if countries can commit, own, and take it as a political choice, and if we can support them to the fullest we can turn the tide, and hopefully we can achieve SDGs, because that's what we aimed for, and we don't need to have another goal. Let's stick to that and make it happen. And I'm hopeful that we can do that.
A resounding call to action. Dr. Tedros Adhanom, thank you very much indeed for highlighting not only the challenges that we're facing, but also the enormous opportunity that we can realize if people have access to quality, affordable healthcare. It's not just the individual, but also communities and entire countries who will benefit from such investments. Thank you both again. Now, Japan is a leader in the pursuit of universal health coverage and understands the level of partnership and collaboration it will take to make progress. We are honored to be joined now by His Excellency Shunichi Suzuki. Suzuki Daijin, yokoso goiso dekite koei desu. This is Japan's Minister of Finance. Dozo. Thank you, sir. Thank you. Yeah, well, Dr. Ted.
First of all, I would like to thank President Banga and Director General Tedros for a very insightful discussion. It is my great honor to make a short statement on Japan's efforts to promote UHC. Japan has long been emphasizing the critical importance of UHC as a foundation for human capital development and sustainable growth. Japan has also been advocating that finance-health collaboration is essential to achieve UHC. For this reason, Japan hosted the first G20 Joint Finance Health Ministers meeting in 2019 at the margin of the G20 Osaka Summit. In this context, I am pleased today to see various stakeholders, including finance and health experts, meeting to discuss UHC. Japan has been closely working with the World Bank and WHO in supporting developing countries towards the achievement of UHC, including through financial contributions to technical assistance in this area. In order to further accelerate our efforts, I am delighted to announce today that Japan, together with the bank and the WHO, will establish a UHC knowledge hub in Japan in 2025. The hub will support knowledge sharing on UHC, as well as capacity building for finance and health authorities. It is leverage the expertise of the bank and the WHO while drawing on Japan's experience, such as our efforts to maintain quality UHC amid an aging and declining population. At the bank, the discussion on IDA 21 is ongoing. IDA plays a crucial role in mainstreaming UHC in low-income countries. It is imperative to help them secure adequate financing resources for a well-functioning healthcare system. Japan expects that IDA 21 maintains UHC as one of the policy priorities. Today, I look forward to lively debate about the challenges and the policy efforts to achieve UHC in each country. Building on today's discussion, Japan will continue to help step up efforts to promote UHC across the world. Thank you.
Suzuki Daijin, domo arigatou gozaimashita. Many thanks, Minister Suzuki, for your important message and for Japan's continued commitment to global health. Thank you very much, sir. Thank you. And now we have 3 questions for you, our audience, here in person and watching online, not just to test your knowledge, but also to help illustrate the scope of the challenge. Please use the QR codes to participate, and we'll share the correct answers with you later in the event. Question number 1. It's a sad reality that women in low-income countries are more likely to die due to childbirth compared to women in high-income countries. But by how much? Is it 4 times more likely, 14 times, 34 times, or is it 140 times more likely? Our second question for you, there's a shortage of healthcare workers in countries everywhere. What percentage of countries have fewer than 1 doctor for every 1,000 people? Is it 3% of countries, 18%, 33%, or is it 43% of countries? And our third question, what do you think is the single most important thing that can help accelerate progress toward universal health coverage? Please let us know in just 1 word. We'll share all your ideas later in this event. So, achieving universal health coverage brings opportunities and challenges, as we've heard, and will require country reforms. Let's now welcome His Excellency Dr. Mohamed Pate, Nigeria's Minister of Health, Her Excellency Sri Mulyani Indrawati, Minister of Finance of Indonesia, and Dr. Sanait Faseha, Vice President of Global Programs at the Susan Thompson Buffett Foundation.
Very good.
Welcome to you all. Thank you very much for taking the time to be here. So, Mohamed, if we could start with you, please. You are leading your country through critical health reforms. What's your vision, and how is it going to change health coverage for Nigeria's poorest and most vulnerable people?
We are a young and fast-growing country, and our health outcomes have been improving over time. But there are other elements like non-communicable diseases that are rising as the fastest growing segment of our morbidity and mortality. Under the President's Health Sector Renewal Investment Initiative, we're expanding access to quality, basic health care through the primary health care system, expanding the primary health care centers that are functional from 8,800 to 17,000, retraining 120,000 frontline health workers and enabling them with digital technology to function, expanding the affordability through the Vulnerable Groups Fund to ensure the poorest and most vulnerable are able to afford the services that they need, to improve maternal and child health, immunization, as well as deal with other elements of the evolving epidemiology that we're seeing of hypertension, diabetes, and other diseases. That is the approach that we're taking so that we can guarantee basic health care to all Nigerians over time, to raise the domestic resources, and to work with our partners in a sector-wide manner as a federal system between the federal government and the state governments, as well as development partners and civil society, so that we pull in the same direction to improve health outcomes. Over time, we expect that Nigeria's health outcomes trajectory will improve, that life expectancy can improve, and that maternal morbidity and mortality will reduce, because many of the diseases are actually preventable with simple things that can be delivered at the primary health care centers. So on our path to UHC, these reforms are getting us closer to saving more lives, reducing physical and financial pain, producing health, and to do it for all Nigerians so that we don't leave anyone behind. That's what we are undertaking right now in Nigeria.
That's the vision, that's the goal. How's it going? What kind of challenges are you facing in implementing and also sustaining these reforms?
It's been an exciting journey. I think we've got the highest level of political leadership from the President. And as Tedros says, it's a political choice. Nigeria made a political choice to prioritize health investment and the well-being of Nigerians. So we're seeing that easing the path. State governors are joining along, and development partners like the bank, like WHO and others also are rallying around this effort. Challenges of human resources are certainly one that is not limited to us. We've doubled the intakes for our physicians, nurses, midwives, pharmacists to increase the production of health workforce in our country, to redistribute them, and also to create the enabling environment so that they can stay and function. That's one challenge. But financing is a key one. And the financing gap that we have, certainly we're very encouraged when we hear Ajay mentioning 1.5 billion, and that's a significant commitment by the bank to actually do that. But then backing it with the resources that are needed. You can scale. For Nigeria, for instance, we can deliver 100 million out of that 1.5 billion if the resources are there. And we're really seeing appetite from our development partners to contribute. Some of these are doing this quietly, and some of them are actually working programmatically, in addition to the technical support, to get us closer to our aspiration as laid out by the President in his agenda.
It's an immense task, but one that needs doing. Ibu Ani, we know that getting healthcare in many countries comes at a very high cost. It puts a heavy financial burden on individuals, on families, especially the poor. Why is this of concern? Why should this be of concern to a finance minister?
Well, I think for the finance minister, the focus of the quality of human capital is very important. At the end of the day, if the economy and the country have a human capital with a better quality, whether on education and health, that definitely is going to create much better quality of growth, inclusive, equal growth in this case. And for a country like Indonesia, with the young demographic dividend, just like Nigeria, this is very important. Investing at the very early stage. And that's why Indonesia putting quite significant resources, both on education and health. And on health, we have the legislation which is mandatory for us to create a universal health access. That's very costly, certainly, if you look at the cost, but the rate of return is definitely very high. Indonesia currently have 95%, which they are all, the people register on a health insurance system, the biggest single player of the health insurance in Indonesia. And that will provide, especially the budget, our fiscal policy tools, providing support for the poorest family and the member of the family to be registered free of pay. And that means we are going to be the one who pay. And that's provide an access of education without out of pocket for those poor family. The problem now is more on a demand side. It's created with those. Then supply constraint. And that's why reform on the supply side is going to be very important. And this is one of the most important reform of health in Indonesia. Indonesia is a very big country, 270 million, comprises of local government, and health is actually delegated to the local government. So you can have an uneven quality of health services across Indonesia. That's why providing a good support, technical capacity, competency, human resource, medical worker, I think that's going to be a very important. Currently, Indonesia is launching this comprehensive reform on health, which is supported by many of the MDBs, and that's why World Bank now hosting this talk show with us.
And to make these reforms happen, you need financing, and Indonesia has been quite successful in mobilizing financing for these reforms. How have you done so?
Well, first, I think the MDBs really look at the country, and they love to have a country who has the strong ownership, they call it, and leadership. So the Minister of Health is important. They have the good Minister of Health with leadership, know what they are doing, do the reform. We passed the reform legislation, which is very important for the Indonesia health system. And this is totally overhaul in terms of how we are going to educate the medical doctor, how we are going to manage the local government hospital as well as health services, especially on a primary level. And then also how this is going to be connected with the insurance system. So these are all become like one important reform, which is not only on a curative, but also preventive. So this is one integrated from the lifestyle into early detection of the disease up to the whole services from the primary, secondary, referral hospital. And of course, we have to make sure that people have a better health lifestyle, so that it can create a much better. So that kind of ownership as well as leadership and a comprehensive health vision is very important to gain confidence from the source of funding, especially this the MDB. The MDBs, which is a combination of not only World Bank, but also Islamic Development Bank, Asian Development Bank. What good about this combination co-financing is they are all now looking the procurement system, one combined simple process, which President Ajay Banga already launching this plumbing improvement by having a simpler, faster, hopefully that's true for us. So that is going to like deliver a much better and also supporting the reform in a credible way. Because legislation has been passed, the discussion with many stakeholders is already being conducted, and so we are going to then support it with the financing.
Thank you, Ibu Ani. Now, Sanait, you have been in the field of global health for many years. You're a physician yourself and a globally recognized leader in reproductive health and rights. How do you think we can collectively do more with the funding that's currently available for health?
Thank you, Shax. I don't think any of the things I will say would come as a surprise, at least to this audience. What we see globally is vertical programming, and I think the single most impactful way to maximize our limited resources is to fund a primary healthcare system instead of individualized vertical diseases. We, as you rightly said, I work in reproductive health. So imagine a woman seeking care, going to one clinic for HIV, another clinic for contraception, and somewhere else for her children's immunization. So rather than doing that, if we pool our resources and essentially do what Minister Pate was talking about and invest it in strengthening the health system and provide integrated service delivery, we can push our resources further. And we at the foundation, at the Buffett Foundation, have seen that. We are a single-issue foundation committed to advancing the health and well-being and rights of women and girls. But by funding governments and strengthening health systems and responding to the government's mandate, we have seen that we can reach many more women at scale, and the services are scalable and sustainable. Unfortunately, global funding doesn't work like that, but I think there are examples we can glean. If you look at the bank's investments, for example, at the Global Financing Facility, and take workforce as an example, right? If you focus on workforce, you're primarily focusing on ensuring essential health services are available, but these are also the tools for strong preparedness, right, for pandemic preparedness. If you look at climate response, first-line responders are healthcare providers. Shout out to my colleagues in Women Global Health for so long who've been advocating women are the frontline providers. So 90% of healthcare providers are women. So by investing in them and paying them and creating a career ladder, you're also then working on gender equity. So I think there's just a lot we could do to pull these strands together and maximize our resources by putting it in a systems lens as opposed to an individual disease lens approach.
Thank you, Sanait. So, Mohammed, you've seen this issue from many different perspectives, from the global level to the country level, from the private sector, and now to the public sector. You're a medical doctor as well. You've worked in an emergency room. You know this issue inside out. So if we were to meet in 1 year from now, what do you hope will have shifted in the global and country discussions on universal health coverage?
Well, first, on the UHC agenda, I think even before COVID, we knew that we were not on track at the pace that we are making progress. Pandemic came and derailed us even further. So going forward, continuing on the same path will not meet our objectives. So there are some shifts that are needed. And with countries at the center, and what we're trying to do in Nigeria is articulated a vision, a direction, defragmented the landscape with the subnational levels also align with us, and having our supportive global partners come to back us up with financing, with technical support, but following leadership of government and using national systems that are more sustainable, and let's hold each other accountable. If that shift occurs, where we're really real from the global perspective, to really deploy the resources, then we'll see the shift in progress towards UHC. So long as we continue with the model that we had, where, like Sened mentioned, vertical funding, hyperfragmentation, various interests here and there, reality is, for the pregnant woman, for the child who is sick, they go to a primary healthcare center. They want to be assessed, they want the health worker to see them, they want the commodities to be there, they want to be able to afford the care. So an integrated perspective is what is needed. So in the case of Nigeria, the Health Sector Renewal Investment Initiative, which was launched by our president, is precisely trying to do that, to pull everyone in one direction, subnational units, development partners, but with a laser focus on results, and results at scale. Not results in one district or one state, and also results focusing on the most vulnerable, the poorest, who are left out. So that's really the shift that I hope we can begin to see in the next year or so. And I will also reiterate for us, for the bank colleagues that are here, for GFF, who are doing an amazing job with us, and many other partners that are also trying to support Nigeria in this journey, that we can put on the table at least 100 million population that can be reached with access to basic healthcare services. So if the bank is really going to go all out for this, Nigeria now, this is where we are and this is where we're going. Thank you.
Thank you, Mohammed. Tonight, last words to you. What gives you hope? Is there anything that gives you hope in the pursuit for global health?
Sure. We're living in very fragile times, and it's very easy to give up hope. But the truth is, there is a lot to be hopeful for, especially post-pandemic. I think the global narrative and conversation on global health has shifted in such a way that we cannot go back. And for me, what I see at this table, the leadership from the Global South, gives me incredible hope. The leadership that I see in international institutions, seeing someone like Tedros, who delivered healthcare for millions of people as a health minister leading the WHO, or Juan Pablo, who was a health minister in Colombia sitting at the GFF and the health and nutrition, population and nutrition at the World Bank, tells us that the world as we know it is changing. And I think external funders need to rally support and throw themselves around some of this change that we're seeing. 80 years of development, I think we've made very, very little progress. I think you all agree with me. We've made progress, but when you look at our expenditure, it should have been much more. And part of it is this very colonial, outdated model of development is not fit for purpose for the time we're in. There's a lot of exciting stuff around the world. When I see what Minister Pate is doing in Nigeria, I recently met with President Ruto and his commitment to deploy 140,000 community health workers. Look at Rwanda boldly doubling down to quadruple workforce in 4 years, because if they continue at the current pace, it will take 100+ years to meet the WHO's minimum requirement for workforce. So there's really strong momentum and leadership. So how are we going to position ourselves to support this change, to support this dynamic, and invest in such a way that allows governments to have ownership? I mean, again, the bank, I know, needs to improve a lot of things, including speed, the way we manage projects, but it's a country-led ownership. It's a country-led process. So I think I'm really hopeful when I look at my own continent and Africa CDC and the new voice for Africa in a unified way to negotiate. I mean, we've seen what happened in the pandemics and who was left behind, but I think it's really hopeful that the world as a whole is awakened to this new reality. And I think if we all rally around that and reform ourselves to be fit for purpose, we can be inching closer to achieving UHC health for all in the real meaningful way.
Thank you very much indeed. Thank you all for joining us to discuss this important issue. With smart country reforms and strong government leadership, change is possible. It's also clear that health and finance ministries need to be working together, because without adequate financing, healthcare reforms cannot happen. Once again, thank you all very much indeed. Now, before we invite our next panel to the stage, let's hear from some frontline health workers. We asked them to tell us one thing that has helped them improve health services for their patients. Here's what they said.
And one of the greatest innovations that has been able to help with care is being able to get ambulance services on time. And that's one of the things that has helped us to be able to care for our patients diligently.
And another intervention that really helped us is the installation of solar lights and rainwater harvesting facility for our center.
También este programa de telemedicina contribuye a tener una atención integral, una mejor atención integral del paciente.
And one of the greatest innovations that has been able to help with this has been the electronic health management systems, which helps me to be able to have continuity of care with my patients, so that none are left behind and we carry them along.
So very important to hear from these local heroes. They need our support to continue their good work improving and expanding healthcare services to people in need. And now, here are the answers to our quiz. The numbers are staggering and really underscore the need for urgent action. Women in low-income countries are 34 times more likely to die from childbirth than women in higher-income countries. And 43% of countries have fewer than one doctor for every 1,000 people. Clearly, we need better progress, and that will require more investments in health. To talk about this, please join me on stage now, His Excellency Dr. Mohamed Ma'it, Minister of Finance of Egypt. Hello, sir. Lamia Tazi. Hello. Lamia is CEO of Sothema, a pharmaceutical manufacturing company in Morocco, and Dr. Joanne Carter, Executive Director of Results, an organization committed to ending poverty. We appreciate you being here, taking the time to be here with us today. So, we just heard Ajay announce that new commitment by the World Bank Group to help countries get health services to more people, 1.5 billion people in 5 or 6 years. Joanne, you lead a global advocacy network in Africa, Asia, the US, Europe, and the Pacific. From where you sit, what will it take to really deliver on this, especially in terms of how we prioritize financing?
Yeah. Well, one thing I would say is I'm not quite sure we celebrated enough that target, because the target that was just announced is a doubling of reach and a doubling of ambition. So I think we ought to just notice that and celebrate it. So that's huge. And what I would say, though, sort of first thing is ambitious targets need ambitious funding to match. Maybe you expected me to say that as an advocate. And of course, it starts with domestic budgets, and our advocacy partners across the world work with their governments, including parliamentary champions, to increase investment in health and nutrition, especially for the most marginalized. But I would say we urgently need also more external grant and concessional financing, especially for the lowest income countries and those facing debt distress. And that's why donor support for an ambitious, robust IDA replenishment, along with support for other key global health institutions, Gavi, the Global Fund, the World Health Organization, the Global Financing Facility, is so critical. And also prioritization of health and nutrition within IDA. And the other thing I would just say about targets is that targets can and should drive us, but we also know from experience that top-line targets, even bold ones, can actually obscure inequities. And so we need to ensure that financing reaches the most marginalized, and that only happens if it is specifically targeted to do so. So to deliver on a goal like this, we need equity between countries and within countries. And just a few really quick thoughts about what we can do. You heard this earlier in the last panel, but a focus on investment in primary health care. primary health care at the community level, especially for the most marginalized, has to be the leading edge of universal health coverage investment. And to measure IDA's impact on UHC, this has to be where we start, focusing on the numbers of people reached with primary health care and measuring it with an equity lens, increasing the share of resources going to the lowest quintiles. And I would also just add that global health security matters, and it matters a lot, but it also matters how we define it. And narrow investment in health security does not reach UHC, and theoretical global readiness actually falls apart if we actually don't have the support and capacity at community level. So just really final point, this is, we also need to build PHC starting there and then going further with human capital investments. And I think it's also a real strength of IDA to sort of start with primary health care, but also ensure access to emergency and higher level care and nutrition supports across this spectrum and across sectors, social sector and program support and gender investments. Because bold targets for UHC matter, and while they don't guarantee equity, we can do things in targeting an investment that ensures equity, and country ambition needs investment, and that needs to include donors.
Thank you, Joanne. Now, we've heard over and over today the need for political commitment. Minister Ma'et, what is your government doing to ensure that all Egyptians have access to effective health care?
I think Egypt, although it was one of the first countries to introduce health insurance in 1962, and the objective was to cover all the population. However, by the time we found that the system did not cover all the population, it became financially unsustainable, inefficient, and also it didn't achieve its objective. So 4 years ago, we decided to change and introduce universal health insurance with a different model and different design. And it based on that we have to split the financing of the system from the affordability or the ability of the Minister of Finance to provide finance or not depends on how the budget is, to create an independent buyer and create all the sources needed to ensure that the system will be financially sustainable for a long time. This is number one. Number two, to ensure that we cover the whole families. Number three, to ensure that private and public sector will compete, and to ensure that the government is not longer responsible to provide health care, but to buy health care for the citizen from whoever the citizen want to receive the service, and created one public arm to provide the health care and to compete with the private sector, and a third organization which will be the regulator. This regulator will be given the accreditation. So 3 different organizations. One is a buyer, one is a public provider, one is a regulator, accreditation, and controls the quality. Over the 4 years, we were able to start rolling out the new system with governorate, and we created financing from different sources. One is social insurance contribution paid by the employee and employers. The second one, earmarking tax and tax coming from the budget. And the third one is that the state will pay the contribution for those who are vulnerable or unable. And every 1 or 2 years, we review the system from the actuarial point of view to ensure the system is sustainable. And we created a mechanism to ensure that the pricing of the health services will be attractive for the private sector and public sector at the same level. So all will compete. So the buyer is just buying the services for the citizen. Over the 4 years, we were able to cover around 5 governorates out of 27, and we are continuing to do that. Satisfaction level, the World Bank, JICA, and the other with us is to review the level of satisfaction and to fix if the system is having something in the design.
You were saying the private sector and the public sector need to compete, but you mean in terms of pricing, right?
They need to compete in satisfaction for the citizen, because at the end, the citizen has the option to choose the provider, whether it is public or private. So this is number one. Number two, they need not to compete on the main cost of the services, but on the quality of the services, because we have an independent committee, which include private, public, and the independent, who price the services to the people. But again, we chosen the slogan of money will follow the patient. So whenever the patient chooses to go for a specific provider, money will go to this provider. And we said the government is not responsible to provide the services, but to buy the services. And this helped us to ensure that citizens will go where they can find quality of the services and they are satisfied of that. The other thing is to ensure some sort of independent for the financing sources. I worked as a first Deputy Minister of Health before I become Minister of Finance. So I felt that leaving the health services at the mercy of the Minister of Finance is not a good idea. So after 1 year of working as a first Deputy Minister of Health, and I was awarded Bachelor of Medicine after 1 year, so I said, when I become a Minister of Finance, I will ensure that not to put the system and the financing of the system depending on whether the budget is in good health so they can allocate more money or not, no. And we were able to build a huge reserve in the first 4 years of implementing such a system.
Thank you, Minister Myatt. Let's look more closely now at the private sector and the public sector. There are also opportunities to cooperate, right? Because they can complement each other. Lamia, you're there in the private sector. In your experience, how can the private and public sectors best complement each other? For example, in developing a vaccine, you need a partnership, don't you, between the private and public sectors?
Yeah. Thanks, Jacques. Thanks for inviting me to have the chance to discuss about contribution of pharma industry in the health coverage. So, as you said, so I'm leading a company which is located in Morocco. And in 2021, His Majesty, our King, decided to give the health coverage for all, which was a very courageous decision, knowing that we had to add 22 new habitants in Morocco in this health coverage. So I was very pleased to be part of this big challenge. And it's exactly the title of the panel, is how to move to challenge to action. And I think Morocco took the good decision to go there. And after 2 years, I can say that it is a success. And this success cannot be here if there is no collaboration between public and private sector. Of course, the chance we had in Morocco is that we had a strong pharma industry before, thanks to some incentives given by the public sector, by our Ministry of Health. We had some incentives to push local manufacturing. So in 2021, 70% of the needs in medications were manufactured locally. Knowing that in the health coverage, 30% of expenses are coming from medication, so it was very important to have this availability of the products, and it was manufactured locally, which give us and give to the public the availability and the accessibility to give the equity for all Moroccan. So at the end, I can say that collaboration is very important. This local production afford the products in terms of quantity because it was planified, it was discussed before, and in terms of quantities and in terms also of kind of medication, knowing that our region can need some molecules that doesn't exist perhaps in other countries. So local production was able to afford this kind of molecules. In terms of vaccines, we discuss about vaccines. My company had the chance to be part of the big adventure in COVID. So it was a real partnership between public and private. I had the chance to conduct the first clinical trials in vaccines in Morocco and then manufacture the vaccines before. And really it was done by very, very close collaboration between pharma industry, between my company and the Ministry of Health.
We're going to look more closely at the benefits of local production very shortly. First, Mr. Ma'et, is the government of Egypt working together with the private sector in any way?
What I insist on when we design this system, I said, no possibility to success in ensuring this system will achieve its objectives without private sector. Why? When we move to some governorates, the infrastructure, the public infrastructure is not there. So I have to rely more on the private sector to ensure that they will be able to provide the service. But how can I attract the private sector? How I can convince the private sector to be with me? Number one, to be part of pricing the services. Dynamic. Dynamic, I mean by dynamic, if the inflation changed, they can call tomorrow for the committee, we need to change the price. And they can, at any time, because they are part of the committee who are pricing for the whole Republic of Egypt, they can change in a weekly basis, on a monthly basis, in order to ensure that they always seeing the system responding to their success, because eventually they look for profit. Eventually they look to get more business. At least unless this business is attractive for them, they will not be joining me. This is number one. Number two is because I'm trying to ensure that what capacity they have will be built in the system itself. So they are on the price, they are on the provider side, and I give them the opportunity to have more and more business. Egypt is roughly 115 million people living, and in some areas the private sector is more infrastructure, more capabilities. So I believe with prices, with good prices, with good volume of business, and they have good infrastructure, they come with us. And also we always make contracts with them on a regular basis to join us. Even the insurance companies, I said for the insurance companies, you can work with us. Why? Because at some level of categories of population, insurance companies are more efficient to deal with those who have the financial capabilities. They want some sort of special health system. So I said, okay, I have a price list. And this price list will be applied for all, because the private sector and the independent experts were there in pricing. So let the insurance companies make the contract with the employers and do whatever services. At the end, every quarter or so, we can make financial settlement. So you are happy, we are happy. At the end, the government wants what? Wants the citizen to enjoy a good health services. For me, I want to be efficient. I want to ensure that this system will continue sustainable. This system will earn the satisfaction of the citizen, regardless who will provide the service, public or private. This is not my job. My job is that the citizens are happy. And I created the money which can support that. I said, the money cannot get from one source. If it is only the budget, I will be under the mercy of the budget and the Minister of Finance. I said, no. We need to get social insurance contribution directly deducted from people's salaries and from the employers to the system. This is number one. Number two, earmarking tax on tobacco and cigarettes and everything come directly. So the tax authority collects this money, not to give it to the Minister of Finance, to give it directly to the system. And at the end, the Minister of Finance is responsible to finance a part of the system, particularly the population who are not able to finance themselves.
Thank you, Minister Ma'et. Now, let's go back to that point about local production. There were important lessons during COVID, the COVID-19 pandemic for many countries about not having medical equipment, tools, and drugs, pharmaceutical drugs, not being produced locally. You manufacture locally in Morocco and Senegal. You're looking to expand into East Africa and also the Middle East. So outside of health emergencies. How does local production actually help increase health coverage?
We know all that COVID pandemic was a really crash test for all, and especially for the health systems. Even I know in rich countries there are many issues of shortage of medications, of all medical devices. So Morocco has the chance to have a good experience on it because of this local production. We were able to provide all medication needed when all important products were stopped. By the way, Sotema is working also in Africa, and we were providing also with the Moroccan approval our African countries and partners, because there were shortage in many of products. So it was very important to have this local production to permit the pandemic to pass away. So I think without this local production, Morocco and Africa will have issues. Now I can talk about opportunities in the health coverage. I discuss about all what pharma industry give for the health coverage. Of course, this pharma industry, as Mr. Minister say, we have also opportunities as producers. Of course, it make the quantities more important. So because of economy of scale, so we reduce the price. So we reduce the price so we can afford more quantities with accessibility, and we know how the cost of the product is very important in the health coverage. So this opportunity, it's in affordability and also in creating ecosystem. Helping this local production is pushing investors to invest more in new technologies, which is a very important point for me. Primary care is very important, but in our region, we also face the same issues in chronic diseases. We have oncology, we have cardiovascular, and these molecules are very expensive for countries like us. So giving the opportunity of local producer is to push them also to invest on new technology, to create an ecosystem in R&D. R&D is not existing in our countries. So I think that, as you said, partnership between public and private is really a win-win situation for all. And from my side, I'm very happy to participate in this adventure. It permits us to think about going outside Morocco and outside our region, which is very important for economy and for writing in outside. So at the end, it's a win-win situation.
Thank you, Lamia. Joanne.
Yeah.
In closing, you've been a strong advocate for universal health coverage throughout your career. You've worked very hard to bring many different players to tackle the major diseases of poverty. How do you think we can keep funding and action for global health as a top priority?
Well, thanks. You know, I would say the thing that I come back to start with is that we cannot achieve these targets for primary health care, for universal health coverage, without more funding for these priorities. So that is so clear. And countries, it's also clear that countries and the most impacted communities need to lead on what's needed. And they need to do domestic financing in ways that protect the most impoverished. But we so need donors to also do their part in the financing. And increasing, again, grant and concessional finance through increasing support for the IDA replenishment, which is in play right now, as well as for other key global health institutions, is absolutely essential for supporting domestic investment and ambition. Also, the Global Financing Facility, which is housed here at the bank, is one of the instruments that can help support countries to crowd in more IDA resources and also more domestic resources for health. And I would say, like, really importantly, where countries are stepping up domestic investment in health and areas like nutrition, this has to be an incentive for donors to do more and not an excuse to do less. And I would also say it was really exciting to hear about the local production, and the UHC will require everyone at the table. And I would also say that in health delivery, we need also a core, strong public health system. And I think that is another strength of IDA, because it actually works across the public health sectors to support that. And I guess, you know, finally, I would say to your question of what do we need to do, I mean, we need ministers of finance who are leaders like this. You know, we need ministers of health. We need the private sector and things like dispersed manufacturing. And we also need members of parliament. I know that there's members of parliament here from around the world whose role on budgets and oversight and as champions is really key. And absolutely central is the role of local leaders, civil society, and especially directly affected communities for setting direction, for holding governments and institutions accountable, and also for resource mobilization. And I would just say, like, to wrap up, you know, I've worked with the US and other donor governments for decades as an advocate. And I know that we have strong allies in those places for global health. And I also know the constraints that they face, right? But those constraints are political and not fundamentally economic. These are political decisions. And so we need to provide public backing for our allies and our champions, but we cannot let donor countries step back at this time. We need them to step up, to fund what matters, and to be partners with countries so that countries can fund what matters to the communities and the most vulnerable. And you know, ultimately, and Dr. Tedros said this at the start, this is a political choice. And we cannot accept that there isn't enough money for this agenda. And we cannot expect countries to try to do more with less. We actually need to increase support for IDA and other key global health institutions so that we can support countries to do lots more on primary health care, on UHC, with more. And we all need to work together to make that happen. So thank you.
Bravo. Thank you all for being part of this very necessary conversation. Partnerships are clearly key to making a dent in improving and increasing health services. Partnerships with civil society organizations who know the situation on the ground. Partnerships with governments who prioritize health and the financing for it. And partnerships with the private sector that can help fill gaps, especially when it comes to medical supplies and delivery. Many thanks to all our guests once again, and thank you to everyone who took part in our quiz and who answered the question, what is the one thing most crucial to accelerate progress toward universal health coverage? Here is what you said. The cloud is up there. So we see money, affordability. Yes, we need more affordable services. All those answers are correct. You've all clearly been paying attention to our expert speakers. And underpinning all of this, political will, and of course, the funding, the money, funding for healthcare ultimately is a fundamental investment for the benefit of all that will unlock future human capital and economic progress. Thank you very much for taking part, for sharing your thoughts. That brings us to the end of this event. We hope it's been informative and engaging for you. You can watch the replay of this session and our other events at live.worldbank.org. Please do continue sharing your comments online with the hashtag WBG Meetings. We'd love to hear from you. We thank you for joining us. Thank you.